Oh my God. It's not unremarkable. It's remarkable. Like, do you want us to start without a chief complaint? Yeah, let's start
no,
with
I wanted everyone to introduce themselves.
Oh, let's introduce ourselves. But I think we ought to start this one without a chief complaint, because I think it would be fun.
Okay, we can do that. Well, before we do that, everyone, thank you for coming to Unremarkable Labs. Big shout out to Dr. Centor for joining us as always. I'm Stephen Alon, one of the chiefs here at UAB, and Sean Carter is another chief. He's going to be manning the board. We're joined by two discussants, Marina and Noah. Why don't you guys introduce yourselves? Marina, why don't you go first?
So my name is Marina. I'm a medical resident from Belarus. So it's like 3 a.m. in the morning right now where I'm from. Yeah. So yeah, that's all I can say.
We love the commitment.
And your English is better than half of ours.
No, I don't think so.
Well, it's certainly better than Noah's. I've heard Noah before. He can't touch you.
I'm not going to disagree with that. I'm Noah. I'm an MS4 in New York City, and wow, Marina, welcome. That's commitment. We love discussing with you today. Good night, morning.
I wanted to do something crazy, so yeah, here I am.
Yeah.
The good thing is everybody here understands. You know, if you told normal people that you were going to get up and be part of a Zoom conference at 3 o'clock in the morning, they'd look at you like, why would you do that? but we can totally understand why you're doing it, and it makes total sense to us.
I hope so.
Okay, so I'm going to put you on the spot. Tell me your initial thoughts just from the basic metabolic panel. Do you know what all the numbers mean?
Actually, no. So nobody in my country writes with a skeleton.
Okay, so this is called the fishbone.
Uh-huh.
And 137 is the sodium.
Mm-hmm.
And sodium is above potassium. So potassium is 4.9. Chloride is above bicarbonate. So this it actually makes sense. BUN is above creatinine.
Mm-hmm.
And over in the corner is glucose. So that's our basic metabolic panel.
Wow.
Everybody in the U.S. Gets that.
So what I think, well,
and you're familiar with the units because some countries use different units for BUN and creatinine, and even for if you have any difficulty with the units, we can help you with that.
No, I know how to convert them. So
okay, good.
Understand it.
Yeah, we'd have trouble converting your numbers, but you could convert our numbers. So.
That's crazy. Yeah. So actually, I look at this BMP and I think that the only normal number is probably potassium. Yeah. And actually it's to the higher limit of normal. So I wonder what happened. So the creatinine is pretty high. I think even without like the known baseline, 3.0 is like too much.
Yes.
So, yeah. So creatinine is high, BUN is high. So probably some AKI going on, raised sodium and chloride at the same time, a little bit raised. So I kind of think about like this massive infusion of normal saline. So probably at work here. So, but it's kind of like the chloride is not too high for it to be the case. Yeah, bicarb is a bit low.
Okay.
So probably some kind of metabolic acidosis going on here. And this metabolic acidosis, I think, is causing some renal problems.
Okay.
My primary thoughts.
So what I'm going to do is I'm going to give you constructive feedback.
Okay.
Okay. So technically, because we don't know anything about the patient, we don't know if there's an acute kidney injury. This could be chronic kidney disease. It could be volume contraction. It could be obstruction. And if someone comes in today with a creatinine of 3, we can't diagnose an acute kidney injury until we've excluded volume contraction and obstruction. Now, most people in the United States use acute kidney injury as slang. Anytime the creatinine's up, they just say it's an acute kidney injury. Everybody knows that I get really hung up on semantics. And so all I will say at this point is that the creatinine is elevated and we need to think about that and not make a diagnosis yet. Against volume contraction is the BUN and creatinine are about 10-to-1 rather than 20-to-1. That's against volume contraction. I agree with you that the potassium is on the upper limits of normal. We probably have a normal gap. So the gap is 12, right?
Yeah, I think so. Yeah.
The anion gap is 12. Somebody in the chat stole one of my favorite questions. If this patient has an albumin of 2, then we would expect the gap to be 6. Then it would be an anion gap acidosis. So until we know the albumin, we can't really be sure. But then you made the assumption that almost everybody makes that I don't want you to make just yet. And that is you're assuming this is a metabolic acidosis. I have seen numbers just like this with a respiratory alkalosis. So for example, let's say this patient had a pulmonary embolism and is breathing real hard to try to maintain oxygenation. With a respiratory alkalosis, I've seen the bicarb as low as 19 or 18. And so until we have either venous blood gas or an arterial blood gas, we can't be sure that it's a metabolic acidosis. And then if it's a normal gap acidosis, then we have to figure out what's going on. Is it, and we'll get to that if that's the case. Does that all make sense to everybody? Now let's get the chief complaint.
Yeah, so the chief complaint, this is a 20-ish-year-old gentleman who comes in with right leg pain and swelling for 5 days.
Right leg pain and swelling for 5 days. Okay, Noah. How does that fit all this?
Yeah, so I'm trying to figure out whether this sort of thinking about right leg pain sort of relatively acutely with swelling. Once you mentioned, whether this is a, respiratory alkalosis, my mind immediately jumps to something like, well, is there a DVT? But I'm also trying to take a step back and think, I don't know off the top of my head whether something like a cellulitis can cause, thinking I guess backing up a little bit more systemically, like a right leg pain could be with swelling, it could be like an infection or cellulitis or like arterial thrombosis or something else going on. I don't know how that would directly fit in with the labs we see here unless there was something else at play. I don't know off the top of my head why a cellulitis or necessarily like a thrombotic event would cause this elevated creatinine.
Okay, I'm going to let you continue in a second, but I want to explain to everybody what you're doing because you're doing something really cool. What you're doing is you're developing a Venn diagram for right leg pain and swelling and trying to match it to a Venn diagram for these labs. And it's not an easy fit.
Yeah,
it's not an easy fit.
Definitely struggling. I'm sure my lack of real fund of knowledge in this case is struggling with that. Yeah.
Why don't we just focus on the right leg pain and swelling first, and then we'll figure out how we'll put the labs together with it. So we have cellulitis and DVT. Anything else? Any
other arterial or venous thrombosis. So in terms of vascular, a compartment syndrome could cause. This would be a little bit longer of a period than I would think, but and then sort of going out any skin and soft tissue infections or non-infectious like inflammatory causes could cause right leg pain and swelling. Even, if there was trauma, a fracture could cause some right leg pain and swelling if there's sort of extravasation of fluid or, a hematoma that developed. Right. So that's generally what I'm thinking of in terms of right leg pain and swelling.
And which of these So let's say the albumin's 2. Then what would you think?
Then, I mean, maybe something, then I'd be thinking about loss of albumin in terms of like nephrotic syndrome, maybe a thrombosis there, or whether there's...
Right, but what would that say about the bicarb?
Oh, then the bicarb, then this is falsely elevated then.
Okay, so here's the deal. The albumin is the major part of the anion gap. And so the point that we were trying to make, and some people in the chat were getting at, is let's say his albumin's 2. A shortcut, this is not the real formula, but the shortcut formula is just multiply the albumin by 2. And so if the patient should have an anion gap of 6 and actually has an anion gap of 12, then that extra 6 would be an anion gap acidosis. Mm-hmm. How would that fit in with right leg pain and swelling?
Well, then I'm thinking maybe of a lactic acidosis related cause.
So this could be, the patient could have cellulitis and sepsis. Mm. So we need to know the albumin for that, but we also need a better history on the leg pain to try to put this together. And I would love to have a VBG. I'd love to have a urinalysis. And we need to know who this patient is. So as our buddies, the magician and the mathematician would say, this is the foreground. We need to know the background for these patients. We need to know, let's say this is a patient who has sickle cell disease. That could explain right leg pain and swelling. It could also lead to some kidney disease. There's all kinds of possibilities. And so with that creatinine 3 and that bicarb, the bicarb could all be from chronic kidney disease, because this is probably this could be significant chronic kidney disease, but we have to sort those things out. And without knowing enough background and some of these other labs, we can't say but so much. What the labs tell us is where we need to go next. So Marina, do you want to go with more history, or do you want to go with more lab tests right now?
I think more history.
More history, okay.
Yeah.
So can we get more history, and that might sort some things out?
Yeah. So in the foreground, he was otherwise healthy, but 5 days ago he awoke with some pain in his lower right leg, and he was having some trouble walking and noticed some swelling around his ankle. He's been having trouble bearing weight since that time. No preceding trauma, otherwise feels well.
Mm-hmm.
Does that help you, Marina?
Well, it helped only to determine that it's acute. So nothing more, nothing less. I think so. No trauma kind of didn't also include or exclude anything. So yeah, probably some background would be more helpful.
Okay, so he describes swelling in the ankle.
Yeah.
And the question is it in the ankle joint versus is it around the ankle? Because if it's in the ankle joint, then we have to think about why would a 22-year-old have a swollen joint, and could that have an influence here? Mm-hmm. Do you have any other thoughts about this one, Noah?
I don't know if I have any. I don't know if it's sort of helped me narrow down or sort of overlap those Venn diagrams in particular, but I'm sort of interested in the previous time before that. I mean, there wasn't any direct trauma, and he was healthy, but like what was going on the weeks and the months before then, and if there's any clue to why he's at risk for.
So what questions would you ask Stephen? Because he has all the knowledge. He can tell us whatever we want to know. So let's go ahead and figure out what what questions we're going to ask Stephen and why we're asking those questions.
So more background information to know his baseline. So is he generally healthy, or there are some like other diseases? I think also history of exposures, because I actually thought like swelling in ankle, so something could bite him probably in ankle if there was no trauma. So probably like some connection to infection could be found like that. And also like the precise localization of swelling. So like you said, is it like the bone, or is it like the soft tissue? So something like that.
Or is it in the joint?
Yeah, joint.
Because the joint would really change how we think about this.
Yeah.
So what can you tell us, Stephen?
Yeah, I think those are all great questions. So in his background, he has no past medical history, has pretty minimal contact with the medical community, but has no known diagnoses in the past, no significant childhood illnesses. And it sounds like you were sort of asking about his exam. So I can give you a little bit of that. So as far as his vitals, he's afebrile, heart rate is 65, and blood pressure 152/89. Breathing 20 times a minute, satting 99% on room air. And in general, he looks comfortable. He's just lying in bed. Really, the vast majority of his exam is unremarkable, except for looking at his leg. So he has an effusion in his right ankle with significant soft tissue and periarticular swelling that extends up to about halfway to mid-calf with significant erythema as well. And it's painful just to light touch. He does have preserved range of motion at that ankle joint, but it is significantly painful. Does not have effusions or erythema over any other joints.
Okay, so Noah, we have a right ankle effusion. What things are we thinking about?
So in terms of this like right ankle effusion, I'm definitely thinking. I mean, he doesn't have a known history of trauma, but a trauma could definitely cause an effusion. We think of like autoimmune, like inflammatory conditions. Even though this sounds like it's monoarticular, there could definitely be some sort of reactive or like idiopathic autoimmune condition that could cause this. He doesn't have any vitals that make me concerned about an infectious cause, but there could be a localized infection without any systemic inflammation going on. And then I guess also they're like the deposition causes. He's a little young to have any like crystal deposition disease, but you never know. And I wouldn't rule it out. And then I guess generally that's what I'm thinking in terms of sort of a joint effusion. And then I guess overuse is also a cause, like an irritative effusion.
So why would a 22-year-old get a septic joint?
So
what do 22-year-olds do a lot?
have unprotected sex.
Exactly. And how would unprotected sex lead to a joint effusion?
Septic arthritis, like gonococcal arthritis.
Yeah, so I mean, I think that has to be somewhere. So there's the regular septic arthritides that we see, like staph and gram negatives. A variety of different organisms can cause a septic arthritis. But in a 22-year-old, you have to be suspicious of GC. Now, could this be endocarditis with a septic emboli to the joint? Sure. There's all kinds of things that can happen to a 22-year-old. I agree with Noah that crystal deposition, gout or pseudo gout are less likely, but they're in there somewhere. Now, it really is surprising that he has a heart rate of 65 with all this. He's in a lot of pain. It sounds like he has some kind of an inflammatory process. So I think we need a health behavior history. So social history is he's 22, but what does he do to put himself at risk 4 diseases?
Yeah, so he lives with his wife, and they are monogamous and have been together for 5 years. He does not drink, does not smoke, does not use drugs, including does not inject drugs. And his current occupation, he works in construction, builds houses.
Let's go back to the labs for a minute. So what were the things that I wanted, and why did I want those?
VBG.
Yeah, so either an arterial blood gas or a VBG would be nice, so we can decide whether we're dealing with a metabolic acidosis or not.
Yeah.
And an albumin to make sure it's not an anion gap acidosis.
So.
Yeah, so let's get those, and then we'll know what the next step is, and then we'll start working on the kidneys.
Mm-hmm.
Yeah, so he got a VBG, which showed a pH of 7.28, a PCO2 of 38, and a bicarb of 18. And then his albumin was 3.4.
Okay, so the albumin of 3.4, you'd expect a gap of 10. It's 12. We can't argue about 2 points. What do you think about his VBG? Write his VBG down.
It's like too abnormal for his vital signs, so it doesn't correlate together. So on VBG, he's much more ill than in real life, so on presentation. It's really strange.
Okay, so this is interesting. So his the VBG bicarb is essentially the same as the basic metabolic panel. But there's a number that sticks out to me that I'm concerned about. What is it, Noah?
This PCO2 is surprising to me.
Yeah. So this is a lack of compensation. So he's more acidotic than we would have thought. Now the numbers aren't exactly the same with a VBG, but he should have a little bit better compensation than that, I think. I don't know. 18 times 1.5 is 27 plus 8, 35. It may be okay. Yeah, it may be okay. But he does have this normal gap acidosis. So why do people get a normal gap acidosis? Now we've done this on a previous one, but if you haven't seen all of them, should we go through my schema for that? You want me to go through my schema?
Yeah.
Okay. So either if it's a normal gap acidosis, then either we're losing bicarbonate, or we're not able to buffer our daily acid intake. Let me explain that last sentence. A normal diet gives you about 1 milliequivalent per kilogram of acid that we have to buffer each day. The kidney is responsible for the buffering. So if our buffering mechanism is not working, and we'll go over that in just a minute, then we're not going to be able to we're not going to be able to maintain our bicarbonate. Now, we heard no history of diarrhea. So there's two reasons that people lose bicarbonate. It's GI losses and lower GI losses. And that would include having an ileostomy, having a colostomy, having diarrhea, anything where you're losing fluid like that. And the other is a proximal RTA. Proximal RTAs are really unusual. Now, I had a proximal RTA for a while because I had acetazolamide. But he's not, this patient's not taking acetazolamide because he told us that he wasn't. And he didn't mention diarrhea. But we still ought to think about that in case we're not getting the exact right story.
Yeah.
And we do that with the urine anion gap. Do we have a urine anion gap on him by any chance, Stephen?
Yeah. Do you want the specific
Yeah,
Just
let's go ahead and go over the numbers just so that everybody feels comfortable with the numbers and why it works, and explain. Let's explain it in some depth.
Okay. So his urine sodium is 42, urine potassium is 10, and urine chloride is 30.
Okay. So think of this equation. The urine sodium plus the urine potassium plus the urine ammonium should be greater than the urine chloride.
Yeah.
Okay?
Yeah.
But his urine sodium and urine potassium are greater than the urine chloride without any ammonium, which means he has very little ammonium.
Mm-hmm.
That makes sense? If he has very little ammonium, that means it's a renal cause. So we've gotten rid of, and it's not a proximal RTA, probably. Now we have to think about why the kidneys are unable to buffer. There are a couple different reasons. One would be a distal RTA. Because, and we've done this before, but try to imagine the nephron. And unless Sean has a nephron drawn someplace for this. Here's the idea. In the proximal tubule, glutamine goes to glutarate. Remember, we learned that in the Krebs cycle. It spins off ammonia. Ammonia goes into the proximal tubule. When it goes into the proximal tubule, it becomes ammonium. So we need proximal tubules to make ammonia and then ammonium. All of the ammonium then leaves at the sodium potassium chloride cotransporter where loop diuretics work and goes back into the interstitium. When it gets in the interstitium, it's no longer an acidic environment, so it becomes ammonia. So part of our countercurrent mechanism is ammonia. Everybody following me?
Yeah.
Then we have to have passive diffusion into the distal tubule. The distal tubule has to be able to acidify the urine, and it protonates it, and it's a great buffer system because it takes microequivalents of acid to buffer milliequivalents of ammonium. So it's a really efficient buffer system. Now, why am I almost certain this is not a distal RTA?
It's rare.
It's rare, but it could happen. We don't have the right history for it, but there's one lab here that tells us this is almost certainly not a distal RTA.
You've got a normal potassium here, well, I guess borderline normal.
Yeah, the potassium is might be high. It's certainly not low, and you almost always get hypokalemia with a distal RTA. So it's probably not a distal RTA. Now we can prove that when we get a urinalysis and just see that the pH is acidic like it should be. Okay, the next reason that you would get it, let's say this is a chronic kidney disease. You make two things happen with chronic kidney disease. You make less ammonia because you have less proximal tubular cells. And remember, we start to wash out the countercurrent mechanism. And so therefore we don't concentrate as much ammonia down in the medulla. So we have we're making less ammonia and we're concentrating it less. So people with creatinines of 3 can get an acidosis just for that reason. Just because they can't buffer because they can't make enough ammonia and concentrate enough ammonia. The last one that we have to consider, and somebody in the chat already had thought of this, could this be a type 4 RTA? So 4.9 is close enough to hyperkalemia that it probably is impacting our ability to make ammonia. It turns out that chemical equation, glutamine to glutarate, the enzyme is glutaminase, and high potassium inhibits that. So anybody who has a high potassium makes less ammonia. The converse is true. Anybody with low potassium makes more ammonia. That may be, although AMK is going to disagree with me, that may be one of the reasons that hypokalemia is a risk factor for hepatic encephalopathy. That may be. it sort of makes sense. So why do people get type 4 RTA? So let's assume for a second that this is a type 4 RTA. Why do you get it? Do you know why you get a type 4 RTA?
So like a hypoaldosterone state.
Right. So
a common cause.
And what kidney diseases cause a hypoaldosterone state? Because he's not on any of the medications that do it.
Yeah.
So it would be easy if he was on spironolactone, or if he was an ACE inhibitor or an ARB. They all will cause a type 4 RTA, but he doesn't have it.
I'm trying to think of specific kidney diseases. I like the RAS blockers. Given that he's not on one, I don't know of anything that would cause like an adrenal insufficiency or like inhibit those.
Okay, so not only is it usually hypoaldo, but it's usually hyporenin hypoaldo. Where is renin made?
In the JGA.
JGA, the juxtaglomerular apparatus. And there is one particular kidney disease, a very common kidney disease, that seems to preferentially attack that. And this is not trivia. This is really big league stuff, especially when you start taking care of outpatients. So it's diabetic kidney disease. So type 4 RTA, your best bet, if they're not on medications, is that it's diabetes. And this is a real problem because a lot of people are on the borderline of having hyporenin hypoaldo, and then they get proteinuria. We put them on an ACE inhibitor and ARB totally appropriately to decrease their proteinuria, and we exacerbate their type 4 RTA, and we flip them over into renal tubular acidosis. Now there are other things they can do. Sickle cell can do it. Lupus can sometimes do it. And so one of the things that I was thinking about is, could this guy have sickle cell, and could he have had a bone infarction? But we don't have that particular history. Now, could a 22-year-old have a brand new onset of sickle cell, of diagnosed sickle cell? Yeah, that could happen. It doesn't happen a lot, but it could happen. But now I think we really have to focus on whether this kidney disease is new or old. We don't have anything that makes it sound like it's new. Do we have a urinalysis?
Yeah, we do. So his UA showed a specific gravity of 1.01, a pH of 6, 3+ protein, no blood, 3 to 10 RBCs, 0 to 5 white blood cells, and 3 hyaline casts.
Okay, so back to Belarus. And one of the things I'm really impressed with is how good your internet connection is, Marina. I mean, it's like you're next door. I mean, this is magic. So what do you think of that urinalysis?
So specific gravity is on the lower limit of normal. pH is actually kind of also normal, but we weight like pH like 4 to 5, not 6. Mm-hmm. So protein, like the biggest concern here, I think, is protein. Mm-hmm. So it's either acute and it's massive proteinuria, which I don't think it is actually, or it's an old problem like we discussed, like diabetes mellitus causing diabetic nephropathy, so wasting of protein.
Right, but it's not diabetes.
Yeah, but it's not
diabetes. See a
diabetes.
glucose of 88.
Yeah.
Okay, so let me help you here. Mm-hmm. So the first is urine-specific gravity, and many people in the chat know that I'm obsessed with the urine-specific gravity.
Yeah.
So 1010, and one of my former residents, who's now a program director, put in the chat, this is isostonuria. And I love that word, isostonuria, because it really takes you a long time to learn how to say it properly. But it means that the urine osm and serum osms are the same. That happens in chronic kidney disease because we wash out the countercurrent mechanism. So this is totally consistent with the chronic kidney disease as opposed to acute kidney injury.
Yeah.
the pH of 6 is a little high, and if the potassium was lower, I might think that maybe there's distal RTA, but I don't think I have to go. I don't think I have to go there, but it's certainly possible that there's some distal RTA. The 3+ protein with that specific gravity. So 3+ protein, if I had a very concentrated urine, so if it was 1.020, I might try to write it off. But this this article that was in the Annals of Internal Medicine that just came out in a podcast that I discussed with a nephrologist, just came out today, actually. 3+ proteinuria is very significant, especially when you don't have a concentrated urine. So that really suggests, and some people had suggested that perhaps we're dealing with nephrotic syndrome earlier. And the albumin of 3.4 in a 22-year-old is pretty low. That's pretty low. So this really could be nephrotic syndrome. So somebody in the chat had previously said we ought to get a urine albumin creatinine ratio. So the podcast that I did and the article point out that all the nephrology societies think that the best test to do once we have this information is a urine albumin creatinine ratio rather than urine protein creatinine ratio because it has better definition. The other thing is 3 to 10 RBCs are concerning.
Mm-hmm. Yeah.
In a man, right? 3 to 10 RBCs. So what does that make you think of?
So actually it makes me think of nephritic syndrome, not nephrotic syndrome. So
and there are mixed syndromes, right? So
yeah.
You can have both nephrotic and nephritic. So this makes you think of some type of glomerulonephritis.
Yeah.
And the question is how much is proteinuria and how much is red cells? And as we've said on this Zoom conference before, with 3 to 10 red cells, what you need to do is call a nephrologist and have them get urine first thing in the morning and look for casts right then, because you can't rely on the lab to diagnose the casts. They don't get the urine fast enough, and they're looking at all these urines. They don't have time to do that. So you really have to focus on. So now, if this is a chronic kidney disease, it could be a kidney disease that is causing a type 4 RTA. It could just be a kidney disease that is causing acidosis just because the GFR, and I don't know what the estimated GFR is, but it's low enough that you could get acidosis just from that. You did mention earlier, could saline cause an acidosis?
Yeah.
It causes a very mild acidosis, if any. I really did a lot of reading on this in a case we had once. And if the bicarb goes below 21, it's probably not just saline. It's probably not just saline. So, Travis says, don't give, Travis, you do give saline if they have a metabolic alkalosis. And, that's the one time that saline is really the right thing to give. But otherwise, most of us have switched over to lactated ringers. So what we're trying to figure out here is what kind of kidney disease is going on and how does that relate to the ankle. It would be nice to tap the effusion, see what we find out. And everybody in the chat was already ready to tap the fusion. Of course you have to tap the fusion. You can't get around tapping the fusion. We have one leg swollen, but we don't have both legs swollen, and the albumin's not quite low enough for us to blame the swelling just on the albumin. So the swelling has to be something else. Is it infectious? You're a little bit more likely to get infectious. You're a lot more likely, as somebody mentioned before, maybe Noah mentioned, could this be nephrotic syndrome and be hypercoagulable because you have nephrotic syndrome? And so could this be some type of, is the ankle effusion really the big deal? So I would try to look at the ankle effusion, certainly let's go ahead and get a urine protein creatinine ratio, call renal, consider doing a biopsy, and trying to figure out. Now, why would a 22-year-old get glomerulonephritis? They just do. So it could be strep glomerulonephritis. He could have had a little skin infection. It could just be bad luck. People get glomerulonephritis for no good reason. Or could he have some congenital disease that I don't know? And I certainly would be going to the books. Somebody mentioned, is this membranoproliferative disease? And that would be a very that would make a lot of sense because we have evidence thinking of a nephritic syndrome, exactly like Marina said, and evidence of nephrotic syndrome because of the protein. So how do you put those two together? This could be not very good story. So
yeah, so I hear calls for further evaluation of his kidney function. So we did get a urine protein, not urine albumin, to creatinine ratio, and that was 9 grams.
Okay, that's good enough to declare nephrotic syndrome. The conversion is actually 300, 3 grams of albumin is like 5 grams of protein.
And then he has, he got a renal ultrasound with Dopplers, which showed right kidney that was 9.3 centimeters, left that was 10.5. They were echogenic with no hydronephrosis and no evidence of renal artery stenosis.
And no renal vein thrombosis.
And no renal vein thrombosis.
Yeah.
And then I apologize, what was the final test you wanted, Dr. Centor? Oh,
we want someone to look at want a nephrologist to actually look at the urine and see whether or not he has red cell casts.
I'm sorry, you were breaking up.
I broke up? Okay, red cell casts.
Yeah, sorry, what were you saying? Red cell casts, gotcha. So nephrology came by and as they do, they spun his urine and didn't appreciate any casts.
Okay. So the question is, what is the differential of, so why would you get red cells alone? What type of kidney disease would give us red cells alone?
Red cells alone.
Without any red cell casts?
Right.
I mean, I
think I remember this.
I think I generally associate red cell casts with a primarily glomerular disease, and so anything beyond the glomerulus could cause red cells.
So somebody help me. I may have this wrong, but I thought IgA nephropathy can cause hematuria, and I don't know.
Oh, yeah.
So help me. Does IgA nephropathy also cause proteinuria?
Yeah.
Can.
Okay, so that would be in our differential. We could get pure hematuria if we had basement membrane disease. Now, we haven't heard anything about the lungs, but you can get just pure kidney disease with basement membrane disease, but I don't think you'd get that much proteinuria with basement membrane disease. And then we have to think about all these other hemolytic uremic syndromes and all kinds of things like that. Do we have a CBC on them?
We do. White count was 12.4, hemoglobin 13.8, platelets 302.
So the platelets 302 is a little high. I mean, it's an inflammatory process, but I think the money's in the renal biopsy. Oh, and we're going to wanted to see if we could tap his ankle.
Yeah, exactly. That's what I was just remembering as well. So we did tap his ankle, and we found negatively birefringent intracellular crystals. We sent off a very large serology panel, which was completely normal. So we got anti-basement membrane, ANA, double-stranded DNA, P-ANCA, C-ANCA, and so forth. It hit Hep B, Hep C, HIV, RPR. We kind of did the work.
Yeah. It's like the renal stamp. Just order all these things and we'll sort it out afterwards.
Right.
The chat desperately wants uric acid.
Yeah, so his uric acid was 11.4.
Okay. So that's really interesting. Any family history of gout?
Not that he knows of.
Okay. Is there a way to put together his renal disease and gout? I'm sure there is, and I don't know it. Does anybody in the chat have a good way to figure that out? The chat is just going crazy.
I'm wondering whether he took anything for his, did he take anything for his pain? Any like NSAIDs that could cause any renal injury?
He just took Tylenol.
Okay.
Yeah, and 9 grams of protein. I don't think we can blame that. Has to be a renal disease. So I think the answer has to be in the biopsy.
Yeah.
And just in 3 minutes, how do you want to treat his gout?
Gout.
He has acute gout. I'm doing this for Sean. So what are your options in treating his gout? You got three really good options for treating acute gout.
NSAIDs?
NSAIDs. Totally contraindicated here.
Yeah.
Colchicine would be a decent option.
Colchicine, yeah.
Yeah, colchicine could certainly work.
And
steroids.
And steroids, and steroids might be the best solution here because it may also help. It may also help the kidney disease while we're waiting to find out what the kidney disease is. I'd probably use steroids. What did y'all do, Stephen?
Yeah, we actually did intra-articular steroids.
Intra-articular steroids. Okay, good.
Which I've never done before. And then, as you guys were calling for, the answer really lies in a kidney biopsy. So they did a kidney biopsy, and what they found was essentially signs of FSGS. And in talking with the pathologist about his whole history and the fact that he had gout with hyperuricemia in a young man with presumable CKD, they felt this was probably secondary FSGS from a hyperuricemic nephropathy. And so we consulted our geneticist and sent off a genetic test for the genes like SCLA4, which is associated with familial hyperuricemic juvenile nephropathy, which was positive.
Hyperuricemic juvenile nephropathy. Okay, good. Who in the chat got that one right?
I think there were several. who had suggested some urate nephropathy.
Yeah.
So that was impressive. So we did a little research on, what that is. So it's an autosomal dominant condition where you have abnormal handling of urate in the tubules, and it's associated with progressive renal failure. Most patients over time do progress to end stage. And unfortunately, in his course, he is approaching the need for dialysis.
Wow. And if once you've diagnosed it, does lowering the uric acid slow down the progression of kidney disease?
Not that anyone has demonstrated, unfortunately.
And so why did he get like this autosomal dominant disease only when he, the acute manifestation was only when he was 22?
Yeah, so that's a great question. Interestingly, he's sort of a classic presentation. So most of the patients tend to present between 15 and 40 years old. So it probably runs in his family, and I'm assuming the kidney injury was probably just CKD that was incidentally discovered in his presentation for gout. And this had probably been building for years, and in the absence of medical contact, no one knew that he had CKD.
It's really interesting. When I started back in the 70s, a complete metabolic panel included uric acid. So we had uric acids on everybody, and now it's not on anybody's complete metabolic panel. So you have to order it separately. But we did talk about crystal deposition disease. This could be crystal deposition disease, especially in the absence of fever. That's a pretty wild reason for developing nephrotic syndrome. So Marina and Noah, what are the two things that we went over that you really want to own after participating? And both of y'all did a great job. Nobody's getting this case right, but both of y'all did a great job.
So
I guess, I can kick it off, I guess. One thing for me really is honing down like that good schema that you mentioned for non-anion gap metabolic acidosis. I think really like thinking about the pathophys way to understand like a urine anion gap really helped out. And then also just sort of taking a step back and trying to link sort of, again, using that Venn diagram approach to a lot of labs. I feel like especially with like the clinical problem solver, is a lot of times we use that for symptoms rather than labs, and sort of taking that approach to link a lab with a symptom was really helpful here.
Mm-hmm. Okay, Marina, we gave you time to think.
So for me, it was also like approach to non-anion gap metabolic acidosis, and also I always forget about different types of RTA. So I can't remember them, like proximal, distal, type 1, type 4. So I always forget. And I can't think in a manner of this. So I can't like picture the disease in my head based on the like structure of the kidney. So like structure of the glomerulus and the tubular system and so on.
That makes you absolutely in the majority of students and residents, and actually practicing physicians. Renal physiology drives most people crazy. It doesn't matter how many times I mean, I love it, but it doesn't matter how many times I say it. People have heard me give the same talk like 3 or 4 times, and they say they learn something new each time. Stephen, what were your big take-home points from having this patient?
Yeah, so one of them was that this entity exists at all, because I didn't know that it was a thing. And the other was trying to, especially in a young man, trying to help unify his symptoms with his labs to a final diagnosis, because he's definitely someone where Occam's razor is probably applicable.
Yeah, absolutely.
And then I just wanted to point out something that I learned from you today that I really had never thought of before, was using the specific gravity to help give context to the proteinuria measured by a UA. I had never heard that before, and I thought that was enlightening.
And Sean, because there's some rheumatology involved in this one, we need your thoughts.
Yeah, I mean, crystalline disease is pretty fun. So I think my thoughts on this one are, when people have minimal medical contact, it's pretty important to be able to recognize, is this a new AKI, is this CKD, or is this CKD with an AKI? And so realizing that, you know, there's a couple things that can help you identify if it's chronic. So like on an ultrasound, if they have smaller kidney size, it might point you toward there's more chronic pathology going on. And then you also do kind of need to see the trend while they're in the hospital and you're doing things.
Yeah. The urinalysis really, there are a lot of things that support this as being chronic rather than acute kidney injury. To me, I knew there was hyperuricemic nephropathy, but not being a pediatrician and not having had pediatrics since 1974, I'd never heard of familial juvenile hyperuricemic nephropathy. But you sort of warned me this morning, Stephen, that it was a diagnosis that I would never have heard of before. The other thing that I got out of this is the chat's awful damn smart. So thank you, chat. And does anybody have any questions or comments? I think this was, hopefully this was very instructive of going at the case from 2 different angles, like Noah said, and try to figure out how to put all those together. And I guess really someone who's really experienced, once they got the gout and saw the uric acid of 11, would know that there has to be some kind of syndrome I think we all would have figured it out even without the renal biopsy, but the renal biopsy sort of just cinches it, and that you had to do a renal biopsy in someone. I didn't know that it would cause FSGS, but that was sort of interesting. So thank you for the great presentation. Have we decided what we're doing next week yet?
We have, but you don't get to hear about it. Yeah, next Tuesday.
No, I mean, not the case. What are we doing next Tuesday?
Yeah, no, I know. We're doing an acid-based case again.
Okay, more acid-based next week. And I think we're starting to plan the next night float. But do we have the great Dr. Tolwani for the following week for acute kidney injury? Has she confirmed?
Not yet, but we are hopeful.
We're hopeful. Okay. Sounds great. Thanks everyone. That was a lot of fun.
Yeah. Thanks, Marina and Noah.
Thank you.
Take a nap, Marina.
Thanks.